right, so it is currently about 12:07 on December 4th, 2020. This is a preparatory NPTE meeting for the students that wanted to show up for prep for the January and or April state or national boards. I'm present, Dr. O'Neill is present as well. I'm going to give her the floor real quick, just in case she has anything she wants to say to you guys, and then I'll come back and take over in a little bit.
All right. Thank you guys for coming and participating. I know there's just a couple of you, but it's important. And I know those of you that'll be watching the recording later. I want to first of all say how proud I am of you guys for persevering through this pandemic and still kind of having the positive attitudes and ability to want to kind of continue on and do, the best you can. So this particular review session, I know Mr. McKeever, was kind enough to offer his time, but just know that we are available for you guys. Your success is our success in many ways, more than one. I don't know. I don't think any of you need any additional pressure than you already put on yourselves to pass this test, because it is, a way for you to actually enter into your career as a PTA. But we also feel additional pressure as a part of our program. We are measured by passage rates as one of our metrics. And so this is really important to us. So it genuinely, truthfully, if you, we will be checking in regularly until January, just not to bother you guys, but just to really get a gauge for how things are. That's why we actually took program budget to purchase those additional PEATs for you guys, because we actually want to show and demonstrate that this is something that's important, and the PEAT is, to the best of our ability, the best way that we can offer you guys a gauge for how prepared you are. So in terms of any additional cardio pulm things, I know I posted a review way back when for you guys in one of the Blackboard courses. I think it was maybe special admin procedures. But if anybody else wants that link, feel free to reach out, email me, and I'll be happy to send it to you and or just set up a meeting to do some additional things. Okay, I'll pass it over to Mr. McKeever.
All right.
And then cap and gown. I believe everybody on here actually has already given cap and gown measurements. And by the time some of you see this YouTube, it might be too late. So I'll send another message out to your colleagues that please, I need height and weight if you want your cap and gown for our January 9th tentatively planned virtual pinning. So, okay.
Yeah, also, like Dr. O'Neill said, if you can think of it, contact the students that aren't here just to remind them to contact her, because that way everyone kind of gets their cap and gown taken care of. It's kind of important. We have to order them in advance. We don't have a stockpile. So just be aware of that. Okay, so let me also, just to let you guys know, I don't know if I sent out to some of you guys, I'll send it out again to most of you. I've made all of the previous NPTE reviews I created public on my YouTube channel. So you can even go back, and there's a couple from, I think, cohort 8 and cohort 7 that are back there. When Mr. McKeever was a little slimmer than he is right now from the pandemic pounds. So you can go back and review those. I'll link to my YouTube channel here at the end. That way you have, and also send it out with the updated on this recording. So let me get my PowerPoint that I kind of threw together last minute, brought up here. Well, not last minute, but I kind of edited it last minute. Share screen. Here it is. I'm going to just spotlight me for this. Where is my controls? There are my controls. All right, so again, this was coming from a couple of things that got sent out to me, and some of the people that can't be here requested some specific things. So the topics that were requested was a question breakdown, kind of including scoring, because some of you didn't understand how the scoring worked or just didn't quite get it. So I wanted to make sure I covered that. Some general test taking skills, pediatric reflexes were requested, lung capacity chart, postural drainage, and ECG, EKG, which I'm going to talk about because it's kind of funny that that's one of the topics that was brought up. So the test itself is broken down into two main kind of groupings. You have work categories and you have body systems. Work categories are divided into physical therapy, data collection, pathology, intervention, and non-systems. And then body systems is broken down into our normal system: cardiopulm, musculoskeletal, neuromusc, integ, and lymphatics, and then other systems, which is where just everything else ends up: the genitourinary, reproductive, stuff like that. So that gets a little confusing, because you may look at a physical therapy data collection and go, how can I have 25 of those when I had 50 cardiopulm? Well, the main reason because that is because the questions can break down into both something of a physical therapy data collection and a neuromuscular or a cardiopulmonary. So it could be something where you're collecting patient data that has a neuromuscular condition. That would fall under both categories then. So the tests are then further broken down by the level of questions, right? We have basically 3 levels. You have a level 1 question, which is our core questions, our level 2s, which are our synthesis, and level 3s, which are the interpretive questions. I'll kind of break them down as we go. A core question would just be a basic foundational concept. That should be a 2-second question, right? It's something like the insertion of biceps brachii. Those questions are going to be worth the least amount of points. So like if you had a 150 question board, which we're going to talk about the total number of questions, and you had all level 1 questions, you'd probably need close to a 125 out of 150 to pass, because those are worth the least amount of points. You're never going to get that. It's specifically weighted, never happen. The level 2 or the synthesis questions now start integrating and applying the knowledge. So, we talked about the insertion of the biceps brachii. Well, now the synthesis is if the patient has pain at the insertion of the biceps brachii, what condition may cause this? Is it a strain? Is it a sprain? Something like that. Now you're starting to integrate the foundational concepts with some kind of looking at what's causing the problem. And then level 3 is your true interpretation questions. These are where you integrate the knowledge and implementation of treatment. These are your most valuable questions. So these are the ones that are going to talk about what is the most safe treatment for a patient with a Popeye tear of the biceps. What is the most safe treatment for a patient? What is the most safe assistive device to walk a patient with cerebral palsy? That's where we get into those interpretation questions. Those are worth the most points. And the scoring goes from 450 to 800, with a passing score being about a 600. On average, if you just went through and kind of guessed, you should get around a 490 to 500 if you just went through and guessed the questions. When the psychometricians took it, so my psychometricians are psychologists who specialize in numbers. That's, if you ever saw the television show Numbers, the one guy on that show was a psychometrician. His job was just to analyze how numbers work, right? So they know how to rank questions board. That's their whole job. But if they sat down and took a PT board exam and just based on guesses ended up with somewhere around 490 to 500. You kind of have to work hard to get under a 490. I'm just saying it's not impossible, but you do have to kind of work at that. So the average number of questions correct on the last exam to get a 600 was about 98 out of 150, or 65.3%. Now, one person may need 98 to pass, while another person might only need a 90. And that's based upon those level of questions, because maybe that person with a 90 out of 150 had all level 3 questions. And that's kind of the way the scores get weighted, right? So then the test is obviously divided into 4 categories. And I know some of you have already taken this, but please just bear with me because I want to kind of hit some important points here, right? It's divided into 4 equal portions of 50 questions. But when you think about, oh my God, Mr. McKeever, you said 150 questions. And I took your math class. 4 times 50 is 200. Well, yeah, that's right. But there are also 50 prelim questions, or what they're called. These are potential future test questions. Unfortunately, you don't know which of those are those 50 questions. They're used to judge the knowledge of new information. Right now, if you saw a question about COVID on the boards that would talk about what is the most effective method to prevent person-to-person transfer of COVID, obviously a mask. Dr. Fauci has taught us that. Right? If you saw that, you would probably have a good chance that that's a prelim question. That's not really something that's in the scope of practice right now, but it may be something we need in the future, because this is not the last COVID virus we're going to face. So this is where they kind of go, okay, what kind of problems are we facing nowadays? And let's start putting some questions in so that in 6 months down the line, we can kind of look at them and add them to the boards. Hold on a second, I'll mute my computer. There we go. So in between sections 2 and 3, there's a scheduled 15-minute break. Now, I've talked to a couple people and they didn't take it. Take it. I think it's 15 minutes, maybe only be 10. They keep changing that on me. So please, last time I looked, it was 15. Get out of your chair. Go to the bathroom. Splash some cold water on your face. If you skip your scheduled break, your brain doesn't get a chance to kind of reset. And when that happens, your body just goes into that terror mode where you're like, I've got to get this done. I've got to get this done. That break is scheduled. That doesn't come out of your total time. So take it, get up, stretch. You can also take a break anytime during the test other than the scheduled break. So if you're sitting there and all of a sudden you're into section 3 and your bladder says, oh my God, I got to go, you can take a break. It just comes out of your total test time. So that's why it's kind of good to get used to sitting down for those block periods, right? So you have 4 total hours to take the test, right? 8:30 to 12:30, 12:30 to 4:30, or whatever the splits are. Get yourself trained to sit there for that long, because that's rough, right? I'm teaching now from home, and it's kind of killing me because I'm used to walking and pacing while I'm teaching. So sitting for that long period of time kind of burns you out. You have to take that break in order to kind of break it up. What I saw when I looked at our numbers is I saw there was a lot of where level test section 1 was good, test section 2 dipped. And then there was a split. I could tell the people that took a break because section 3 picked back up, and the people that didn't take a break continued kind of going down. So that break period is important to kind of reset your brain. So don't skip out on your break. Even if you only take 5 minutes of it, take 5 minutes. It's better than not taking a break at all, right? So then question breakdown. Question marking's the big. You can mark any question for a review. But the big question that I had a couple of you ask is, well, what questions should I mark for a review? Well, your best answer here is to divide those questions into a couple of categories. Questions you know the answer to. You know, you get a question that's the origin of the biceps and you know it. Don't mark those questions. Answer them, move on with life. Don't think, well, you know, I could go back and look at this. I want to go back and look. No, you've got the answer, move on. The more questions you mark, the longer you're going to take reviewing them at the end of the section. Those questions should be in and out, you know, that cor pulmonale involves the heart, move on, right? Then question 2, section group are the questions that I'm confident that I got the right answer. So these are the ones where your gut says you're right. You don't want to necessarily mark these either, because normally if your gut says you're right, you're probably right. If you go back and review them, you're going to change the answer. And the only time you should ever change the answer is if you know you made a mistake. I'm going to talk about that with test taking mistakes in a bit. If you know you screwed up, change the answer. If you didn't screw up, don't change it, right? Your gut is usually right. And then question 3s are those questions that I haven't had the foggiest clue on Mars what they're asking about, right? They're asking about where the frenulum is, something like that. And you're like, I have not a clue. Mark those questions and move on. Don't sit there spending 20 minutes going, well, B looks good, but you know, C's talking about ice cream and I really want some ice cream right now. Don't spend time on those. Mark it, move on, and come back to them. The reason I say mark and move on and come back to them is because you may be at question 2 and that's a question that you don't know the answer to. Question 14 might relate to question 2. And then you're like, oh yeah, that's what they're talking about. They're talking about that little thing on the heart. Then you can go back at the end when you do the review and just take care of it. It prevents you from getting stuck on a question, right? I'm going to talk about this when we talk about, you know, making mistakes, because a lot of people, they get that question number 3 or whatever, and that question 3 is just a question they have no clue. It looks like it's written in Aramaic. You don't even know what it's saying. And so then you're sitting there, you have no idea. You spend 5 minutes on it. And you're like, I don't know. So you go into question 4. And then question 4, you're reading it, but in the back of your mind, you're going, that question 3 was really hard. And then you go into question 5, and you're like, you know, maybe I should have chosen C for question 3. And you go into question 6. And in the meantime, you haven't read the previous questions you've just gone through. And so you end up making mistakes. Don't get stuck on questions you don't know the answer for. Either mark them and come back to them, or choose an answer and move on and don't worry about it. Right? There's no point in dwelling on questions you don't know the answer to. Now, the more you mark, the more time you're going to spend going over them, right? So don't mark 50 out of 50 questions. Why would you mark the whole test? Ideally, if you look at successful test takers, and these are people that maybe don't have all the content, but are pretty good at just doing tests. They mark less than 10 questions out of 50. So about 1/5 of the questions. You know, and then you go back through them at about 2 minutes a question, right? And you've gone on in 20 minutes of a review session versus, 100 minutes of a review session. So that comes down to the Pete, right? Dr. O'Neill was gracious enough to help us get some Petes for people, and I appreciate it. Just absolutely, like no level talking about it there. we have multiple testing resources, right? We have the score builders. The score builders questions are worded more like the PEAT, and the books and resources are designed to institute integration of knowledge and put some fun into studying. Great study tools. There's also the therapy ed book. And I always found the therapy ed book to be a little bit more cerebral and more difficult, because that book, and you can get extra copies of it. They don't have the current version ready yet, I don't think, but they make the questions really, really wordy is the best way I can put it. They process this to make the questions harder so that the NPTAE will seem less hard, right? And they're more focused on fact over function. So they're really focused on just, here's the hard data. It doesn't always work for people. I find that Score Builders is probably one of the best resources for most general people. And there's other test taking resources, right? There are various other companies out there that provide test taking. Their team's one of the ones I've been talking to. Just be careful when you're selecting these, right? Because the two that were selected by the FSBT to be closest to the boards were Therapy Ed and Score Builders. Doesn't make the other ones bad. It just means you have to be a really critical consumer when you're looking at any of those products, right? But ultimately, that PEAT is the most correlative scoring that applies to the NPTAE. If you get a 600 or over on your PEAT and did the test fully on your own, you're likely to get a 600 plus on your NPTAE, right? I used to say shoot for a 600 plus and you're good to go, but with the changes, the question scoring, and just to be safe, I now say you really want to be about a 610 plus to be 100% good to go. And that's 600 to 610, or actually even 595 to 610 range. You're there, but you've got to make sure that you hit all you dot all those I's and cross all those T's in order to pass the boards, right? If you score less than 600 on your PEAT, it's not saying you're a bad person, but you may just want to reschedule. It is much better to reschedule and, take a little bit of a rescheduling fee than it is for you to fail the whole boards, have that weighing on you, and then have to pay for a totally new boards, right? Don't put yourself in that kind of a mindset, because as soon as you fail those, that sets up in your mind, oh my God, I failed. And you've got to get that out of your head and get on to the next test. So when we're looking at taking a test, the tests are broken down into a couple parts, and the national exam will be exactly like this. There's the item. That's the whole multiple choice question. And then in that item, what your goal is to find the stem. The stem is the part of the multiple choice question that asks the question. This is what is the best? What is the least? Which of the following treatments is most appropriate, right? That's the part you want to look at. There can be a whole paragraph of just what we call distraction, and then only one stem that you're like, oh, so they're just asking, how to measure a parallel bars for a gait. You've got to find that stem to find out what the question they're asking for is, right? Especially paying attention to those most, least, is, not type ideas. And then you go below the stem and your choices are called options, right? Those are the options in the multiple choice question. There's always one correct answer and then 3 distractors. And the distractors are the ones that make you go, oh, that looks yummy. That looks like a good answer there. And you get down to C and you're like, oh, dang it, they got me again. It's C, right? Those distractors are meant to be difficult, right? Just remember in the NPT, it's not always the best or most aggressive treatment you saw in your clinic. It's based on the safest treatment for the patient. If it's got a gait belt in the answer, it's probably the right answer, right? We talked about with autonomic dysreflexia, stand them up and check the catheter. It's all about the safe treatment for the patient is the best possible answer. And there are several types of mistakes that people make when they're taking the NPTAE. So these are the kind of things you want to look at. You can have a knowledge-based mistakes. And knowledge-based are, yep, guessed it, didn't know it, didn't study enough, right? You had no idea what the frenulum was. You had no idea what fremitus was. That's just a knowledge-based mistake, right? Then you have choice-based mistakes. These are the questions where you look at and you go, man, I know the answer, have the knowledge, but I picked the wrong out of the two. Chose the wrong answer, right? You got down to 2 questions and you're like, B and C look good. I think it's B. Or you didn't read the question thoroughly enough and missed the not, right? And those are the questions when you go back and review them, you're like, why did I pick that one? And everyone's done that. And then you have the killers, because the test taking based mistakes are the ones that just absolutely murder you on your score. These are the ones where you messed up on your choices, right? And when you're taking a paper test, I circled B, but I filled in C, but I meant B. Right? Totally did not read the question despite my exceptional knowledge. You missed keywords in it, right? Or you changed the answer. Those are all test taking mistakes, right? The mission that you should have when you're doing this is to look at the questions you get incorrect on your practice exams and decide whether you made a knowledge-based, choice-based, or test-based or test-taking error on your question, right? Obviously, minimizing all of those is best, but you're not going to always have all the knowledge. Even I don't have all the knowledge, right? I just went through and Chris asked for some questions to kind of review through. I just went through and did a 25 question quick, just general exam and didn't even really read the questions. I just went down and picked some answers, right? Even I'm going to make mistakes just quick glancing at things. It's just the way it is, right? But minimizing those mistakes is the goal. And I picked some answers on specific purpose just so I could examine some of these. What I suggest is every time you complete a test, take this little kind of sheet here and fill it out. Go through and go, okay, so out of my 50 questions, I got 10 incorrect. Out of those 10 questions, I had 2 knowledge-based, 4 choice-based, and then I had, what was it, 2, 4, 4 test-taking mistakes. And then go look at those test-taking mistakes and figure out how to fix them, because those are the killers. Those test-taking mistakes are the difference between a 599 and a 600. I can't tell you how many times I've heard someone say, oh, in section 2, I clicked the wrong button. You got to minimize those. Don't let those kill you. So that's the basics of the whole thing, right? But the main idea, trust your gut. It's probably right. You made it through a program. You made it through a rigorous, 75-week program. You made it through your clinical affiliations. You would not have made it through it if you could not sit for the boards. So trust your gut. It's probably right. Don't change your answers, right? Don't change them unless you know you made a test-taking mistake. Focus instead on answering more questions quickly, decisively, and then moving on. Don't dwell on questions, right? Yes, question 4 is hard, but if you spend the next 7 questions dwelling on it, you'll miss 50% of them because making test-taking mistakes. Mark it or complete it and move on. Don't dwell. Again, I cannot tell you how much dwelling on a question will kill you. When we looked at, I was on a focus group at the FSPT, and they talked about different reasons why, or different effective techniques that people chose for studying, right? And what they kind of looked at. Well, they weren't making note cards maybe for themselves. That works for some people. It didn't work for me, right? The number one thing people say they didn't do is they didn't put the appropriate time into studying. They admit, oh, I said I was going to study an hour a day, but really I studied 15 minutes, right? Or I didn't study at all. Or I said I was going to study every single day and I didn't study, right? Those are the things that are important. You've got to put the time in. It's just like anything else. I had a student back in cohort, 4 or 5, who is a bodybuilder, just huge jacked guy. And he wasn't putting the time in. And I said to him, I said, look, what do you put into your body when you're getting ready for a competition? And it's like, well, I eliminate everything else I'm doing. I don't go out. I don't play video games. I don't do it. I said, good. Do the same thing for your boards and you'll pass. And something clicked in his head. He went from getting a 500 on his, or essentially a 500, so about a 45% on his first score builders test, to passing the boards with a 678 or something like that, because it clicked in his head, right? What it is the more you put into it, the more you'll get out of it. So you've got to set time. If you're going to do 2 hours of studying a day, do 2 hours of studying. And if you don't do 2 hours today, you maybe only do an hour and a half, you got to put that half hour onto another day. This is just like going to the gym. You know that if you go to the gym on a regular basis, it's easier to go to the gym. But you miss one day, and it gets easier to miss the next, and it gets easier to miss the next. We're creatures of habit. So the more you kind of drill in, okay, so from 9 a.m. to 11 a.m. every single day, I'm going to sit down, I'm going to study. Sit down and study for that time period. Study in the time period that you're going to take the boards. If your boards are at 8:30, study at 8:30. If your boards are at 12, study at 12. That way you're mimicking the time that you're really going to be applying it. Take breaks and take naps. There's a lot of studies out there that show when we rest our brain, that memory gets transferred into the hippocampus and it gets saved. If we don't get the appropriate rest, it doesn't work that way. I don't sleep a lot to begin with, but I know that even if I don't sleep my little bit, I'm less of an effective at anything, whether it's going to the gym, whether it's doing teaching, whether it's whatever it is. Your body doesn't operate on no sleep. You can think, oh, I'm really good, I just need my caffeine. All that is making you functional. You need rest to encode stuff, right? Get up after you study and get up and go for a run or go for a walk. Any of that can really help you in saving stuff. I've seen people that they said, I study best when I'm walking on a treadmill. Great, do it, right? Whatever works for you. Just make sure that you put the time and effort in. Don't get to the end of the boards, not pass your boards and say, well, yeah, the reason I didn't pass is I didn't put the work in. Don't do that. It's just cheating yourself and you just wasted time and effort on yourself. So let's talk about a couple different topics that we had requested here. So we're first going to talk about pediatric reflexes. And the first thing you'll notice with pediatric reflexes is, oh my God, there are so many reflexes and the dates vary. The book says X months, while the test prep says X months -1. How do I know what's right? How do I know what's wrong? Right? Categorize your reflexes into generalizations. Also understand, and we're going to talk about this for all these topics, because these are all really specific topics. You might get 2 to 3 questions on pediatric reflexes, only because it's a neuro topic. But it's not going to be your whole boards. And why do these questions stick in your head? Why do you go, oh my God, I should have known more about pediatric reflexes? Just because you didn't have those in your brain as well. Those type of questions stick in your head, and you seem to forget the 15 questions about Parkinson's because you nailed through them, right? So when I say categorize them into generalizations, let's look at one. So we got the gallant, right? The gallant is where you touch the skin along the spine from the shoulder to the hips, and you see lateral flexion to the side of the stimulus, right? It should start integrating within 20 weeks of a gestation to about 2 months after birth. That's a huge range. But what it says is it needs to be integrated 2 months after birth. Forget the range, right? When you get a test question, they're either going to present you with options within that range, so it'll be less than 2 months, or something outside that range and it'll be well outside. Like it won't be 9 weeks, which is pretty close to 2 months. It'll be like 4 months after birth. And so they're going to ask you whether the reflex is normal or abnormal. So they'll say something like, you have a pediatric patient who's at 20 months post-birth, and they're showing a negative gallant reflex. Is this normal? Well, no. 20 months after birth? No, that's way abnormal, right? Or they may say that they've got an integrated gallant reflex within 14 days after birth. That's actually normal. It can happen that quick. Doesn't usually, but it could. That's within the guidelines. At that point, it's normal. It just is. Right? So you have to know what's abnormal or normal, or the job is to know what the reflex is needed for. And the months don't matter. So they may talk about the reflex was integrated at, 6 weeks. And they're not even talking about that. They're saying, well, what is this important for? Right? With the gallant reflex is critical to the development of balance, right? So that when you move stuff, you can feel it. It integrates at the vestibular, the spinal or vestibular spinal nerve and everything, and kind of get your body to upright posture. If you don't have it, it can lead to scoliosis, right? So that's kind of some of the things that you look at. Oh, well, this could do this or this could do that, right? So break it down into groupings, right? So we looked at, here's a quick kind of chart when you're looking at these. So all of these kind of look at like plantar grasp reflex, or actually let's look at palmar grasp, because palmar grasp says onset should be at birth and integration should be by 4 to 6 months. So what do I do if I'm studying this? I go, integration should be by 6 months. I don't worry about the 4 to 6. Integration needs to be by 6 months. What does it do? Does pressure to palm, and when they pressure the palm, they flex their fingers. Well, what's that going to help with? Grabbing things, right? Holding a bottle, right? Grabbing onto the couch so they can start to get that creeping along the couches, right? Another great one, STNR. This is a wide range. Look at this. Starts about 4 to 6 months, goes 8 to 12 months. So what do I do here? I go, well, it starts at about month 4, should be integrated by about month 12. That's all I worry about. I don't try to worry about the ranges. They're not going to ask you a question saying that the patient's got an abnormal reflex and they're at 11 months. They're going to say that it's 13 months and they haven't integrated. Or they're going to say it's not 13. 13 is even too close. They're going to say something like 18 months it's not integrated. They're not designed to get that close to the question. So don't totally freak out about these, right? But overall, what is the goal of most of our pediatric reflexes? It's to get baby upright and walking. So what are some things that we can do to help the patient get that way? Well, tummy time, right? That's one of the biggest things you'll see a lot of the doctors recommend, right? Getting the patient over under their belly. Why? Because belly is for crawling, creeping, and all that fun stuff, right? Tummy time is important. Interaction with baby, right? There's tons of studies out there that show if baby doesn't get interaction from parents and family, they don't integrate these reflexes. Then it makes sense. If they don't have anything pressing into their palm, they're not going to integrate the palm or grasp reflex. If they don't get somebody kind of bouncing them up and down on the floor, they're not going to get the plantar grasp reflex integrated, right? Those kind of things. They're not going to learn Moro. They're not going to get the tonic labyrinth. So all of those kind of have to integrate with baby getting normal interaction in the real world. Then we get down into the development. So you have your reflexes, the primitive reflexes, and then you have development. And when we talk, when I go back to reflexes real quick, reflexes come back into play when we start talking about strokes and TBIs. Because when you start talking about patients that have a stroke and TBI that have these ATNRs, STNRs, stuff like that, that is absolutely abnormal. Right? That means they've got an injury to their brain. If suddenly you have ATNR again, you've got something going on in your brain. This should have been integrated by, when you were a child. So that's different from reflexes to when we get to development. Development is just, when should baby do stuff, right? When should they roll over? When should they sit by themselves? When should they sit unsupported for 10 minutes, right? When should they start to crawl? When should they start to creep, right? And crawling, remember, when we talk crawling, right? Crawling is army crawling, right? Creeping is up on hands and knees. Sometimes we confuse those two. Sometimes we think that, oh, well, creeping is what army men do and crawling is what babies do. Well, in reality, they're flipped around, right? So when you do a belly crawl, think of it, if you're ever seen military movies, that's where they get under the barbed wire and they're climbing just on their belly and sliding through the mud, right? That's what babies do when they first start going. Crawling's when they get up and start, or creeping's when they start getting up and all over the place, right? Then we have cruising, right? Cruising's when we start getting up under the furniture and start getting brave, start looking up at mom on the couch, right? Maybe trying to take some steps and move over towards dad. Start looking for where my bottle is up on the couch, that type of a thing. All of this is going to come into play with just the baby developing normal, right? Now, what happens if the stuff isn't normal? Does that mean the baby has, MR? Does it mean they have some problem with their brain? It could also just mean baby's a slow developer, right? It just happens. I took a long time to walk as a baby. Don't know why. No clue, but I did as a baby. I think I turned out normal. Well, okay, maybe not. But it just takes. But here's the deal is if the baby doesn't hit milestones, there's a lot of studies that show if you miss this milestone, you miss this developmental milestone, you're going to miss more, right? Because it took me longer to walk as a baby, it would have taken me longer to recover from falls. It would have taken me longer to learn how to run, right? All of those come into play. That's the difference between a development standpoint and a reflex standpoint. Reflexes lead into development, right? But without those reflexes integrating, we can't have development. So then we got lung capacities. That was the next question I had. And lung capacities are by far the most hated topic in any profession. Even in respiratory therapy, they hate the lung capacity chart, right? And respiratory's got to know a lot more than you guys do. So when we're talking about it, it's important to understand when you're looking at a chart or you're looking at the stuff to understand the abbreviations, right? ADS, ERV, FEV, FEC. You have to understand what they are. So I'm going to go through the different definitions and then we'll kind of talk through them. So anatomical dead space. This is the air in non-breathing areas. So this is the area that, isn't filled with oxygen that you're actually, inspirating and expirating, right? Expiratory reserve volume, the amount you can exhale after a normal exhale. So if I take a normal breath and I exhale, the expiratory reserve volume is how much I can then continue, and I'm doing it while talking, right? Continue to exhale after a normal exhale. And eventually I'm going to hit the point where I reach the point where I have no more air in my lungs and I can't talk anymore because I've now hit my ERV, right? That's how much air you can exhale after a normal exhale. Forced expiratory capacity is the maximum air you can exhale. So I take a deep breath in and I breathe out. That's that point where I get to, I can't exhale anymore, right? Remember, with normal inhalation and exhalation, right? Exhalation is a passive motion. You're just kind of letting the air in and out. So when you receive forced, it means you're working on it. Forced vital capacity is the amount of air that can be forced to be moved within the lungs. I often think of forced vital capacity as what you do before you dive, right? You're trying to fill out those lungs and stretch them out so that when you dive down, if you've ever done, free diving, that your lungs are expanded to the maximum capacity they can to store oxygen so you can stay under longer, right? Also, if you do that, like I just did, you get a little bit lightheaded, right? Functional residual capacity. This is the amount of air lying in the lungs after a normal exhalation, right? So this is going to include the expiratory capacity or the expiratory reserve volume, and also some of that stuff that's just lying in there. So the amount of air just sitting in there. Inspiratory capacity is the amount of air that you can breathe in. Right, the maximum you can pull in. That's your inspiratory capacity, right? Inspiratory reserve volume. This is the amount you can take after your normal inhale. So if you look like expiratory reserve volume, the amount you can breathe out after a normal exhale. Inspiratory reserve volume is the opposite. So if I take a normal dip, just a normal breath, there's my normal breath, right? Inspiratory reserve volume is forcing more air into my lungs. So that's how much more I can breathe in. And all of this is going to depend upon your pliability of your lungs and the pliability of your chest wall, right? Minute volume ventilation, this is the amount of air inhaled and exhaled in a minute. That's all it is. So they're going to have to measure that, right? They can measure that with an inspirometer. Peak expiratory flow is the flow of air during exhalation. So how does it move? Residual volume is the big one that you're going to come into questions on, because residual volume is the amount of air stuck in the lungs after a maximal expiration. So if I take a deep breath in and I breathe out normally, and then I force more out of my lungs, even when I get out of here, I can still talk because I still have a little bit of air in my lungs. That's the residual volume. Right? The residual volume is a problem with COPD because it goes from 25% up to a lot. So now they've got just this dead air sitting in their lungs and they're not able to breathe as effectively. Tidal volume is just normal breathing. So volume breathe in and out just sitting here, right? It's a really low amount. It's only about 10% of your lungs. Just kind of normal. If you're sitting watching, British Baking Championship or something like that, tidal volume is the amount of air that you're moving without even thinking. Your TLC, right, is the total amount of lung in the air. Yeah, air in the lungs, right? That's all it should be 100%. Your total capacity should never be on more than 100%, right? Now, what if I've had COVID and I've had infiltrates, which I have? Now my TLC is going to be lower because infiltrates have caused part of my lungs to be kind of scarred off. So now instead of having 100% TLC, I may only have 95%. That's going to affect all my other volumes because now I don't have that total amount in my lungs anymore. And your VC or vital capacity is the maximum inspiration followed by a maximum expiration. So this is where you breathe in and then breathe more in And then you breathe out passively and then breathe out forcibly. That's going to be your maximum, your vital capacity. So if you look at that, the vital capacity plus your residual volume equals your total lung capacity. Those are the formulas kind of want to look at. So that's why this chart to me made the most sense to me. There are multiple charts. If you find a chart that works better for you, mazel tov, use that chart, right? But for me, this one worked the best, right? So it looks at, here's my inspiratory reserve volume. If you look, my tidal volume is just that quiet breathing here in the middle. Let me get my little annotator up here. Right, here's my tidal volume. That's just the amount that's kind of going in and out when I'm sitting here. So if I look, my inspiratory reserve volume plus my tidal volume equals my inspiratory capacity, right? My expiratory reserve volume plus my residual volume equals my FRC, my functional residual capacity. All of these together, all four of these equals this. These two equal this. So they all have formulas out there. Yeah, it's important to understand that there's not going to be a ton of questions about formulas, but it's mainly understanding what's going on. So if a patient takes a breath in and then breathes out and then forces more out of their lungs, we're talking about the ERV, right? And this is all going to come into play when we talk about, because the other thing we talked about was percussive, somebody wanted me to go over. This is all going to come into play with that percussive therapy as well, right? Because if you have what I like to call, I think I have it next, lung butter, right? Lung butter is where you get gunk stuck in your lungs. And this can be for a number of reasons. It can be pneumonia, it can be cystic fibrosis. It can be, right now we have with COVID, right? All of that can lead to lung butter, right? And lung butter is, I call it that because that's what it kind of looks like when it comes up. It looks like butter. You need to know even this postural drainage, but mostly this is being handled by RT in the real world now, right? The only time we typically do this is children with cystic fibrosis, or, right now we're a little bit more involved just because of COVID again, because they need all hands on deck to help get these patients cleared. It's important for you to understand that you know these, right? But you may feel like you're getting a lot of questions on it, but it's only going to be maybe 1 or 2 questions. It's much better to focus on the ins and outs of Parkinson's than freaking out and totally focusing 2 days, focusing on postural drainage. Get the basis of it and then move on, right? So there are a couple things to remember about postural drainage. Number 1, you have to know fremitus, right? And fremitus is that lung vibration that helps you determine maybe where they might have a blockage. So that's where you're going to put your hands on their back, right? Skin on skin, not on their shirt, because you need to feel the skin. And you're going to have them repeat 99. Why is 99? Because it has a specific tonal volume in the lungs that helps feel vibrational portions of their lobes. So you have them say 99, 99, 99, 99. You're going to feel the lobes. You're going to move your hands down and down and down. And a fremitus sign would be maybe where your left hand, you've got a vibration that's different than your right hand. Okay, now I've got something abnormal. Do we diagnose as PTAs? Nope, absolutely not. We just go, okay, so their right superior lobe or upper lobe is vibrating at a greater frequency than their left lobe. That's it. That's all we would report on, right? It's up to the PT to diagnose why that's happening, right? Or even the RT probably be the better option at this point. But fremitus can help us maybe determine where we need to do percussive therapy. So we're going to have patients sit up nice and tall, hands on their back. Okay, Mr. Client, go ahead and let's say 99 as loud as you can repetitively until I tell you to stop. 99, 99, 99, 99. And the whole time you're moving your hands until you feel some difference in vibration. And then you're going to mark that in your brain. You can also mark it if you want to do a skin marker on them. But I just mark it on my brain going, okay, so the inferior lobe, I've got a little difference. Does that mean that you're diagnosed and their inferior lobe is having a problem? No, just you know that you've got a different tonal volume there, or tonal volume. So that can say, well, maybe there's a blockage or a plug, or you got some lung butter there, right? Maybe now we need to do some percussive therapy. And percussive therapy comes in 2 main techniques. You have percussion and you have vibration. There's also postural drainage, but I'll talk about that, right? So percussion is, playing the drums on them. That's percussive therapy. Vibrations where you lay your hands on and you just kind of vibrate back and forth. Typically, it's better to start with vibration to kind of loosen things up, do some percussive, and then finish with vibration. It's a much more comfortable technique for the patient. It's kind of like when we did massage, where we started with effleurage, we maybe dug at them with some petrissage and some trigger points and all that, and then we went back to effleurage to calm them down. It can be seen almost as a panacea, or more importantly, it triggers gait control. You just sat there and pounded on their body for 20 minutes or whatever. That vibration kind of calm things down a little bit and make them feel a little bit better. But any way you do it, you're going to get sputum, right? That's that lung butter coming up. And when you have that lung butter, you've got to get how much it is. Is it a small amount? Is it a moderate amount? Is it copious? Copious is one of my favorite words. I don't know why, but copious amounts of lung butter. What's the color? Is it green? Is it red? Is it black? Is it orange? Is it purple? Right? The color is the thing you need. The important things to note in the color is, are there coffee grounds in it? And when I say are there coffee grounds, you'll see little chunks of black flecks in the black and brown flecks in the sputum. If that's the case, you've got dried blood in the lungs. And that is really important to let a PT know, or a respiratory or nursing, right? We also need the consistency. Is it runny? Is it thick? Is it serous based? Is it more, white blood cell based? What does it look like? Is it in the napkin and it's literally running out the side of the napkin? Okay, it might be thin, right? And then finally, the wafting test, right? What does this smell like? Does it smell sweet? Smell sour, right? Does it smell like Fruit Loops or fruit striped gum? Well, in that case, we might be worried about somebody having, excessive sugar in their body. There's all kinds of reasons we need that. Most of the times, this is why most people don't like doing this, is because they don't want to look at the amount, the color, consistency, and smell of stuff, right? But it's important, when I treat a kid that has CF, it's really important to understand if that's lung butter that's been sitting in there for a long period of time and I finally cleared a plug where that's really thick and just globulous, or is it really thin? In that case, the patient's doing his home therapy and drinking appropriate amounts of water, so it's actually getting out a lot better. So postural drainage has to be used in conjunction with the ACB, the active cycle of breathing, right? So diaphragmatic breathing, breathe through belly, move to stage 2, we're going to go to lateral expansion, right? And then stage 3, forced expiration, where you're either coughing up or huffing up lung butter. And depending upon what style of thoughts you go with this, a lot of times we use huffing when we've got problems with the sternum or the abdomen where we can't let the patient cough, or they may have to splint, right? Hold that pillow. In most of my treatments I've been with, and this is just the way my PTs wanted it done, was they wanted coughing first to get the stuff up into the upper parts of the bronchial tubes, and then huffing to kind of get the rest of the gunk out. So the cough is that deep, right? Whereas huffing is, and that huffing is kind of what you think of when you hack up gunk. So the coughing kind of moves it up, huffing moves it out. Now, coughing may just move it out, right? I remember when my dad was passing away of cancer of the esophagus, man, every time he coughed, lung butter was coming up. And I just like using the term lung butter because I know it's making somebody in this room uncomfortable. So before you teach or do postural drainage, you have to make sure they understand ACB, because let's say I do the upper lobe on the right side and the patient's like, oh, I can feel gunk. You got to sit them up. You got to do some ACB and get them to cough it out, because that way you get that cleared, right? Now, maybe they don't get anything. Maybe you're just moving stuff. You're moving down through those lungs and all it's doing is kind of breaking up the stuff. Well, when you sit them back up, you've got to do a cycle of ACB. You've got to clear that gunk out, because if you don't, all that happens is once you've broken that stuff loose and you sit them up and you just leave them alone, all this stuff just settles right back where it was. So you've got to make sure they understand 3 cycles of breathing, right? Postural drainage can be done by a gravity. So the positions that we have for postural drainage, they can be done just by having the patient lay in those specific positions, right? percussion's the most common, but even in percussion, we're going to put them in a position of gravitational concept. You're going to put them in a position where the lung lobe you're working on drains into the main bronchioles, right? There's going to be positions where they're either in Trendelenburg's, semi-Fowler's type idea, so that it angles those lobes at the appropriate angle, so that if you're pounding on them, the stuff's moving into the bigger tubes, right? That's why it's kind of important to understand the anatomy of the lungs. If you don't understand the anatomy of the lungs, ACB doesn't matter. So here we got the kind of pictures of those upper, middle, and lower lobe, right? So we've got the upper lobe, most portion of the lung, right? We've got the middle lobe, only on one side, right? Why don't we have a middle lobe on the right or the left side? Well, because the left side's got the cardiac notch for the heart, right? We got lower lobes on both sides. And if you look, lower lobes are a little different in shape on both sides, but they're in the general same vicinity, right? And then if you look on the right picture there, it kind of shows you where they are on the human body. So most of your upper lobes are going to be superior to T4, right above the nipple line. Your middle lobe is going to be at the nipple line and just below it, right? Because we don't want to, when we do percussive therapy, we're not going to be snacking on the nipple. We're going to be snacking just below it, right? And then your lower lobes typically are accessed via the back, right? Because it's easy to find them out, right? Here's my inferior scapular angle. I'm going below it, right? You can also get it from the side here, right? So here's my axilla. I know that right below my axilla, I've got that. If I find my nipple line and I draw a line straight back, I'm in the lower lobe region. So there's a couple of different ways you can memorize that. Why is that important? Let's say I do Fremitus testing with them and I notice that his left lower lobe has a reduced tonal volume. Oh, okay, well, then I'm going to focus on clearing that area. But either way, it's just like when you clear lymphatics. If I don't clear the upper portion, I can't clear the lower portion. I've got to get everything out up here so that I can move the stuff that's down here up here. Now, is it possible that I clear the upper portion, they cough up gunk, I start clearing the lower portion, that stuff gets stuck in the upper portion, I have to re-clear them? Sure, it absolutely is, right? Remember we talked about a vestibular where that rock in the brain or rock in the ear can kind of move around and get stuck somewhere else. Same thing can happen here, right? I can go ahead and I can get this area clear, get this area clear, and I start working on the lower lobe, pushing the stuff up, and it falls back down into my upper lobe because maybe the patient's set up weird or something like that. Oh, then I got to go back up here and work upper lobe again. Right? There's not much I can say about it. Sometimes it happens. It's not that you did something wrong. It just happens. So this is out of your physical rehab book. So these are the exact specific areas you're going to work on with postural drainage, right? And if you look, all of them have an angle with the exception of maybe the upper lobes in the anterior segment. And what it is the goal for when you're doing these therapies is if this is the way my minor bronchioles are shaped, I've got to do compressions or percussion. So it's pushing that way. So it gets out here in this area and the person can go, bleh, cough up lung butter. Right? Sound effects included. So yeah, is it important to understand the full general anatomy of the lungs? Sure. I mean, looking at these bronchioles, they all go in different directions. The goal though is to get anything you've got up in here and out. That's the point of all of this. So how much force? A lot of force. This is not little tight little pitter patters. No, this is pretty effective cupping, right? We're not going to slap. It's not a bare palm. It's a cup, right? You want to hear that kind of air pop when you're doing it. What are some contraindications to this? Well, any type of rib or spinal fracture is going to be a definite contraindication here. Don't want to do this if they have those fractures. Could I do the opposite side? So maybe they've got a rib fracture on their left side. Could I clear the right side? Ugh. That's going to be a PT decision, not our decision, right? If they say to do it, okay, the PT's cleared you to do it, but make sure that you're not just totally whacking on them, right? It's not time to re-injure that side that's broken. But most of the times that they got a fracture, we're going to hold off on doing it, period. What if they're on anticoagulants and we do this? Well, they're going to bruise to high heaven. And we've got to be careful because those bruises could stay and it could cause other problems. So we have to understand that. You know, maybe your PT saw them for the eval and said, we're going to do percussive therapy because they've got cystic fibrosis. They come in to see you and they're like, you know, the doc just put me on Plavix last night. That's a red flag. We got to go let the PT know. Tell you what, I'm just going to let the PT know about your new medication change. If you can just give me a few seconds. In the meantime, I'm going to set you up in the upper lobe portion so we can at least do gravitational postural drainage. Then we just switch to doing gravity, letting gravity kind of get the stuff out. So maybe do a few minutes of 3 minutes of sitting in the upper lobe portion, then do some ACB. Do some posterior segment of the upper lobes, then do some ACB. Do anterior segments, do some ACB without any percussion. So that's kind of the goal of these. There's not a magical study guide for this or the lung volumes. The only thing you can do at that point is just memorize them. Those are rote memorization questions. You know, a level 1 question would be why you do this. A level 2 question is going to look at, you know, what position to put them in for maybe anterior segment. And then a level 3 question is talking about the diseases that are affecting them with this problem, right? So ECG or EKG, we're getting away from using EKG. We're now getting more to use ECG, electrocardiogram, right? And again, this is kind of funny that people ask about this because they ask about this. And then iontophoresis is another one that I always love getting a question on because people forgot, I got one question about iontophoresis. I'm going to fail my boards. Probably not. But much like postural drainage, we're not ECG techs. We're not cardiologists, right? So don't totally freak out about these, but let's get to the heart of the matter here and talk about the different types of waveforms in the ECG, right? Now I've got a picture coming up, so don't totally freak out yet. So we have the P wave. The P wave is when the atrium depolarizes. I think my picture's coming up here next, right? So my P wave here, right? Right here, this is where the atrium is depolarizing, right? If you remember, I'm going to use this as kind of so here's minus 70 millivolts, right? Here's minus 50 millivolts. On that action potential curve where we're just sitting here and we got those graded potentials coming, they hit this, boom, there fires off that action potential and they get up here to depolarization, right? This is just talking about that action potential curve. So at a P wave comes along, a P wave is the depolarization of the atrium. Right, that's when that, and if Dr. O'Neill chimes in with anything, she's feel free to, but I'm just going through the kind of lesson. She's much more versed in CART than I am.
I think I won't chime in. I think the most important thing is from what I've heard from those that have taken the boards is this level of introduction, knowing what it is and what we use it for.
That's exactly why I did this way. Yep. Because I don't even memorize all these. Right. Even PTs don't have all these memorized. I'm going to tell you, they don't.
Yeah. And I only do because of my work in cardiac ICU. Right. So that honestly, so that's it. If I were not have had those years, I can't imagine that I wouldn't have a need to have all the rhythms. No.
Right. And I look at EEGs from doing neuro, but I doubt that Dr. O'Neill has any idea of how to look at an EEG, or maybe she does, but maybe, you know, I can look at an EEG and figure out which is right brain versus left brain and stuff like that. That's because I've worked with EEGs before. I haven't worked with these a lot. So this is the level you kind of need to know. So we have our P wave. Well, if we have a PR interval, it's going to be this interval, the timing between your P and your R. So if we go over here, right, the PR interval is going to be right in here. The PR segment is the part after the P wave, and when we get down here. So what's happening at that PR interval? It's the time for atrial total depolarization. So the P waves when the atrium starts depolarizing, and then the PR intervals when the atrium fully depolarizes, right? Then we go into the QRS complex. That's when the ventricle depolarizes and the atrium repolarizes. So it goes back to that minus 70, sitting at that neutral kind of firing. So if we go down here and look at this QRS complex, right? Get my little drawer here. So here's my QRS complex. At this point, my ventricle is starting to fire off, and my atrium, where the P wave happened, is starting to calm back down. That's what you kind of need to know about the QRS. The QT interval is where ventricular depolarization occurs combined with repolarization. So you can think of that a lot like going from the P wave into the QRS complex for the atrium, right? Because P wave is where the atrium depolarizes. QRS is where it repolarizes. QT interval is where the ventricle depolarizes and repolarizes. The ST segment always follows the QRS. It makes sense because it's by alphabet, right? The ST segment is a lack of electrical period where ventricles become depolarized, right? It's part of that action potential when everything starts going back to normal. And your T wave is the ventricular repolarization. So if we look here, here's atrial polarization, right? Starts going down. Now the ventricle fires off. At this point, if you remember back to that action potential curve again, right? So I did this. At this point, my atrium's starting to get down here into this hyperpolarization region. So it can't do anything. So the atrium's kind of sitting there and it's lame duck right now. And that makes sense because it just pumped all that fluid down into my ventricle. It doesn't want to do anything more, right? It's got to stay kind of closed off so the ventricle gets all the blood. And then it's going to come back up and get ready for the next pump, right? That's here when we kind of get into that QRS. And then the ventricle is going to fire off. That's the next one to go off. And the ventricle is going to squeeze. And whether it's the right or the left depends upon where the blood goes. But all of this is going to come into play and kind of look at what a normal heartbeat looks like. So we should have a nice little lump, a dip, a spike. That's the way this is the way I always remember it is. We have the speed bump, we have the pothole, we have the speed hump, another pothole, and then the speed bump. That's the way a normal EE or ECG should look, right? Now, what happens if we have something weird? Well, first of all, if we have normal sinus rhythm, meaning the heart's beating normally, atrial depolarization happens, spreads normally through the heart from the SA node down, right? And the AV node's firing off. You get 60 beats to 100 beats per minute. That's normal heartbeat, right? Sinus bradycardia is lower than 60. Sinus tachycardia, greater than 60. A sinus arrhythmia is where you look at and I've got a couple examples coming up here, so don't totally freak out. Sinus arrhythmia is where you have quickening or slowing of the impulse of the SA node. And the heart rate varies beat to beat. So this is where you're feeling a patient's pulse and it just doesn't feel like it's at a nice, neat, even like boom, boom, boom. It's a boom, 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 right? It doesn't feel normal. That's an arrhythmia. There are multiple arrhythmias out there. But sinus arrhythmia, you've got something going on, right? And then we have sinus arrest. This is where the rhythm is an intermittent failure of the SA node and impulse formation or AV node conduction. So something's happened where it's not transiting down. If we go into sinus arrest, that can eventually lead to full-on cardiac arrest, right? So we need those SA nodes and the AV nodes to be firing in order to functionally pump blood to our body. So this is kind of looking at a normal EEG or I keep saying EEG, ECG, right? And again, this is looking at voltage versus time. That is what an EKG or an ECG is looking at, voltage over time. Now, important to know about ECGs, it's a snapshot. This doesn't tell us why their heart's acting that way. It doesn't tell us what disease they have. It just tells us at that given moment, I was tachycardic, or at that given moment, I was bradycardic, right? I'm going to use my personal example. When I went in, so Dr. Hill's been here a year, about 4 years ago, when I went to the ER and I was complaining of chest pain. Initially, they thought, or I wasn't really chest pain, it's chest tightness. Initially, they thought I was having an allergic reaction because I looked like an allergic reaction. So they sent over a respiratory therapist, and the respiratory therapist administered albuterol to me in a high dose of it. Well, for those of you who don't know what albuterol does, albuterol sends your heart rate through the roof and sends your blood pressure through the roof. So then I'm sitting in the ER and my heart rate is like 150 at rest, blood pressures, I think it was like 150 over 95 or something stupid like that. And the cardiologist comes in and starts freaking out. He goes, "You're having a heart attack." And so they slap a nitro patch on my chest. And then it throws off my segment even worse. And by the process of doing those two different things, it really jacked my signal that by the time I got to the cardiac floor, my ECG did not look like this. My ECG was all over the place. I had depressed, QRS signal. I had no T wave, and my P was a dip instead of a hump. And they're like, "You're going into congestive heart failure. You're going to die." And I'm like, "How can I die? I just ran 5 miles this morning." And all it was medicine induced, right? Now, does that mean that I don't have heart problems? So my family has a history of heart disease. Of course, I've got heart problems, right? But this is just a snapshot. They took an ECG from me 2 weeks later, and my ECG looked normal from me. I have a left bundle branch blockage, so it looked normal from me. But it's only a snapshot right now, right? This is all over the place, right? Suddenly you look at the ECG and it's bouncing all over the place. Stop moving the patient. Because probably moving them is throwing the ECG lines all over the place, right? You want to look at it when the patient's at rest so you can take a good look and see this nice smooth flow. What happens if you see something that's abnormal? You come in and they've got no R point. Talk to the nurse. You don't have to diagnose it. Don't have to worry about it. That's not your job, right? You come in and they have got a depressed P wave. Talk to the nurse. Make sure it's cleared to work with them, right? That's their job to manage this. And I got news for you. If they're on telemetry, there's a telemetry tech somewhere monitoring every single heart rate. And they know before you know that there's a problem with their ECG, right? Especially if you're one of those people that come in to treat a patient and forget to tell the ECG tech that you're going to be working with the patient and pull the leads off. And now the patient flatlines and the ECG tech literally has a heart attack themselves, right? So this is just kind of the normal way it looks. So here's kind of a quick from a cardiac book looking at how it talks about the P waves, the atrial depolarization, the PR segments, the conduction through the AV node, uses a baseline to evaluate ST elevation or depression, right? PR, atrial depolarization plus conduction, QRS, ventricular depolarization. The ST, so down here is isoelectric. Ventricles are depolarized, meaning they can't contract anymore. We know that from that action potential curve, right? We got the QT is ventral depolarization plus repolarization. And then the T wave is where the ventricle repolarizes, goes back to normal. This kind of helped me a little bit when I was looking at one of the cardiac books, so I just wanted to get that in there. This is some abnormal rhythms. So let's say you come in, you're working with the patient, and you see the patient with that very, very top rhythm. And you're like, "Hey, Mr. Johnson, I'm here from PT to work with you." And Mr. Johnson's not responding. And you look up and you see that first rhythm. It's meaning that they are in VFib. What should you do as a PTA at that point? Anyone have a guess? You suspect the patient's in VFib. What should you do? I'm going to take somebody take a guess. You should get this one. This is easy. Is anyone still awake? I'm talking to no one. Call a code. There, I'll throw you a hint, right? Tell the nurse, call a code. VFib means something's happening, right? That for when you see fibrillation, that means the heart is doing that, right? It's just kind of fluttering. Not fluttering, because fluttering is another thing. I want to say that. It's quivering. It's not effectively contracting. It's not effectively contracting. Life is not sustainable, right? One of two things is going to happen. If it's the right side, it's going to back up through the lung or back up through the aorta or the aorta. Oh my God. Through the vena cava, you're going to get some backup in the blood and you're not going to get everything going through the heart, right? If it's in the left side, you're not getting blood out to the body and you're going to back up in the lungs. You're going to get all kinds of problems there, right? VFib is bad. VTAC is really not that great either, right? VTAC's where the heart's just freaking out, right? I always like Torsades de Pointes just because I like the name of it. That's pretty much the only reason. That definitely does not look normal, right? Any three of those, you see any three of those, it looks like a kid is drawing in the ECG, get the nurse and call a code. What happens if they're not having a heart attack or well, okay, you called a code, bad, yes, patient's alive, good, right? Supraventricular tachycardia, also bad, right? If you look at that, that still doesn't look normal. STEMI, you'll hear about a lot, right? ST elevation, myocardial infarction, that means they're having a heart attack. My heart rate looks like that one there in the middle, that AFib, right? Everything's kind of erratic. I don't know if I can get a copy. I'll find a copy of mine that we can see kind of what it looks like for real life. I've got AFib and a little bit of aflutter. So it just kind of looks weird. PVCs, look at that. You've got weird dips going on. That's usually what I remember with PVCs. With sinus brady versus sinus tachy, they're both normal heart rates, just at different speeds. If you look at it, it's regular. It's just either fast or slow. Why could they get sinus tachycardia? Maybe you've got them up exercising. That can throw them into tachycardia, right? We normally get tachycardia when we exercise. But in general, there should just be this normal hump, dip, spike, dip, hump, right? And you can hear that beep, 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 right? That normal EKG sound, or the sound from, there was a cartoon about that, or not cartoon, an ad about that with the I Gotta Run Away song. But you're just looking for that kind of normal flow, right? If it looks normal, it is normal. If it looks abnormal, ask. Right? Let's say that you see somebody with any of those top three waveforms. Your number one answer should be stop therapy and get help, right? That would be a safety question there. Sinus tachycardia, patient's got high heart rate. What probably should be an idea? Check their overall Borg perceived rate of exertion and see if it's just that their heart's picked up, right? What if they're in bradycardia? Well, they could be in bradycardia because of their medications as well. You put them on the treadmill and they're trying to walk at 4 miles an hour or something like that, and their heart rate's not picking up. Well, that's also because their medications could be affecting them, right? So it's really important to kind of understand that. So Dr. O'Neill had made some comments over here. She was responding to Natalie. Okay, good. Or to Kaylin or Natalie. Kaylin and Natalie. But yeah, so all of this comes into play here. The main thing for us is we don't walk in and automatically diagnose. If they're in VFib and somebody hasn't already noticed that and they're on telemetry, we got a problem, right? What else could throw these weird artifacts on their EEG or ECG? Well, what if a lead falls off? That can throw an artifact and make it look weird, right? But you just want to make sure, number one, that all your leads are on, right? And if one falls off, just pop it back on. It's pretty easy to see if you've got all the pads and one's hanging off, that's where it goes, right? It just clips on. It doesn't, not like you're sticking it into the patient, right? And what happens if you accidentally disconnect their ECG, right? It happens, just like anything else. Fix it as fast as possible and let nursing know, right? I've had it happen where, I'm I don't want to disconnect them from the wall, so I'm walking them around the bed and back around the bed. And for whatever reason, they get one of the leads caught on the corner of the bed as I'm walking around the bed, and it just unplugs it from the wall. At that point, everything kind of freaks out. I get it plugged back in. I'm like, yeah, my bad, right? But all of these are not our job to diagnose, right? Why does a patient have a STEMI? Not our job to diagnose, right? The key thing I always learned about the STEMI is that you've got that weird ST elevation, right? And you can see SVT, supraventricular tachycardia, looks a lot different than sinus tachycardia, right? It's very fast and it's usually 150 to 250 beats per minute. The heart is going to fail at that point. But overall, you don't have to totally freak out about these. If you're going to work in a cardiac ward, yeah, absolutely. You better start knowing these. And most of the time, they're going to have specialized training and help you with it, or it's your job to get some training on this. We had an education session a few semesters ago, and I may ask one of the, oh my God, I'm trying to think of which doctor is, one of the guys over in respiratory Dr. Barger is a cardiologist, and he actually gave the NPT, or the Nevada Board of PT, or Nevada APTA, an overview of this. And man, when he did that, he was like down in the weeds on this. And we're going, oh my God, this is more than we ever need to know. Because again, you have to understand how to look at the ECG, but you're not diagnosing it, especially as a PTA. What happens if you notice something weird? Let somebody know, right? You notice something is off, let somebody know. You talk to a nurse, get something to that effect. Don't totally just go, oh, well, you know, I've got to figure out why they're having VTAC. No, you don't have to figure that out. Get help. Right. So when you see these, most of these questions when you're looking at an ECG is going to be safety related. Yeah, you notice patients in VFib. What should you do? Probably call a code. The patient's going to die on you. Right. I'm just saying that glibly, but truthfully, right? These are the things you have to kind of pay attention to. The mobile ECG, right? I've had that happen too, where it says that the mobile ECG died, right? So you put the little pocket ECG, you're walking down the hallway, and all of a sudden you hear over at the nurse station, and you're like, oh, please don't be my patient. Sure enough, the battery died in the packet, and people are going, you got the broken ECG. Thanks. Right? So one of the things I usually do when I grab that portable ECG is I change the batteries just to be safe, so I don't end up with that. But that was basically it for the questions session that I had. Now, I had some, Chris had asked to kind of look at a couple questions so that we could just kind of look at some things together so we can kind of rule some things out. So I did bring up a quick score builders exam here just so we can look at a couple questions together, just so we can rule some things out. So let me bring that up here. You should be able to see the what do you call it, the browser now. So just looking, I just want to look through a couple of these questions. I'm not going to go through them all, but let's just look through a couple of these. And I picked a couple of answers wrong on purpose. So here we have a 48-year-old female rehabilitating from a femur fracture and asked a question about her functional level following rehab. Assuming an uncomplicated recovery, the most accurate prediction of functional level would be based on what? So your key word here. So that is your item, right? That's that item. You need to find your STEM. The most accurate prediction of functional level. There's my STEM. That's what I'm looking for. And I've got a most, right? So I purposely picked compliance with the home exercise program because I'm like, okay, well, frequency of therapy visits, pretty important, right? Previous medical history, well, I just said uncomplicated recovery, so I'm not worried about that. Well, I got prior functional level and compliance with home exercise program. So I'm down to the last two and I picked wrong, right? Well, let's think about it. The most accurate prediction. Compliance with home exercise program is going to be important, right? But more important than that compliance is going to be the patient's prior level of function, right? If they don't have a prior level of function that's good, right? Maybe you're seeing a patient, they've only ever walked 5 feet. Their outcome's probably not going to be that great, right? But now you got, oh, well, the prior level of function is what the right answer, right? Oh, okay, now it makes sense because it was the most, right? This would be one where you made that test taking mistake and missed most. Like, well, the most important thing is, are they compliant with their home exercise program? Because we know that is an important factor. But the most important or most accurate prediction is going to be that prior functional level, right? What if you have her and she was an athlete? If you're saying, well, it's an uncomplicated recovery, if she's an athlete, she has a really good chance of coming out really well, right? Also, I'm going to add into the fact that it says she's a female. So, honestly, guys are really kind of babies when it comes to fractured femurs. So she already has, and that's part of her prior level of function. She's female. She'll probably come out a little bit better. Guys are going to whine. I'm just going to admit it. We do. So let's look here. PTA treats a patient with epilepsy that was admitted into a rehab unit 5 days after total hip arthroplasty. So probably what happened here, patient had a seizure, fell, broke their hip. What setting would be initially the most desirable when treating the patient? We've got our whole item. We've got to come here and go, okay, we're looking for our setting that is most desirable. Well, therapeutic pool. Why is that ruled out? Well, if they have a seizure, they're going to drown. Hopefully not with us there, but probably not a good idea as kind of the first couple of days, right? Physical therapy gym. What's the problem in the physical therapy gym? Well, physical therapy gym, you're going to have other people there. You're going to have lots of movement going on. You have lots of distracting things. Not the best place for them initially, right? Because we want to try to tamp down anything that could cause them to re-seize. Hallway adjacent to the patient room? Maybe. But what if you got nurses running back and forth down the hallway? You know, what if you've got the, like some of the hospitals have those little robot cars that drive up and down the hallway delivering medications. All of those are distractions. Private treatment room is the most desirable because I can control that room. I can close the door. I can turn off the TV. I can move everything out of my way. So in case the patient has a seizure, they land on the ground and they can recover normally, right? That gives me the most effective and most desirable area to treat the room. So if I'm looking at this and I was doing this question, I go, okay, 1 and 2 out. So I'm looking at 3 and 4. Okay, well, hallway's good, but not better. The 4 is the best. PTA identifies an infant. Oh gosh, we got an infant. I'm already starting to freak out. Is unable to roll from prone to supine. What reflex could interfere with this ability to roll? So now you have to think about, how does an infant roll? Well, like everyone else rolls, right? Whether you're an adult or you're a child, you roll the same way, right? So you've got to go, okay, so what reflex could stop me? And you're looking through this. Okay, well, I'm going through this and going, okay, the ones I need to get rid of, Morrow, has nothing to do with this, right? Morrow is that startle reflex, right? Positive support reflex deals with sitting, not caring, right? So those 2 are out. So then I've got ATNR and STNR. And I know that ATNR is this, right? Could that interfere with me rolling? Yep. There's my answer. I'm moving on. I'm not even worried about STNR at that point, right? That's just knowing it. Now they could have added in there, if they could have added in this question saying, you know, this infant is at 16 weeks and blah, blah, blah. 16 weeks doesn't even matter at that point. They're just asking what reflex could bother them. PTA completes a developmental assessment on an infant. Uh-oh, not again. Developmental assessment. Are we going to initially do that developmental assessment as PTAs? This would be a follow-up, right? And we could theoretically do the assessment. We're just not going to assess why we get the results we get. This is just we're going to do the testing, hand it off to the PT, and let the PT write the goals and expectations based upon what we get. So this is going, what age should the infant begin to sit with hand support for an extended period of time? So I'm looking at this question and I look at it and I go, okay, 3 and 4 are out because I know babies. And if a baby's not sitting by 11 to 15 months or 10 to 15 months, we got major problems. So I know those 2 are out, right? By 10 to 15 months, we're moving on to other movements. So then I'm down to 6 to 7 or 8 to 9. Well, I know that 8 to 9, I'm still in the movement period. So 6 to 7 is my only logical option at that point. 6 to 7 is the right answer, right? So that's where you kind of got to break these questions down. So we have PTA administers an ultrasound over a patient's anterior thigh. All right, so we've got modalities. So this would be when we go back to those different types of questions we have, right? This is dealing with interventions, right? And integumentary when we talk about this, right? Anterior thigh. After 1 minute of treatment, the patient says, oh my gosh, it's burning. The most appropriate action is, so we know because we have a burn and we have most appropriate, we're looking for safety, right? So let's look at our options. Explain to the patient what she feels is not out of the ordinary when using an ultrasound. Burning is out of the ordinary, right? Now, if we're doing cold, when you're going through the C-band, there is a little bit of burning there, right? But an ultrasound burning is not normal. Temporarily discontinue, we'll come back. That's the right answer. Discontinue treatment and contact the referring physician. Does the referring physician have anything to do with us doing ultrasound? Nope. Well, maybe. I mean, tangentially. but that's going a little bit step too far, right? Continue the treatment using current parameters. Shut up. I'm just going to keep going. No. Right? So 3 and 4 are out. So our number one choices are 1 and 2. We know 1 is wrong because that's not safe. So the only option we have is temporary discontinue treatment and examine the amount of coupling gel. What else could cause the problem? Maybe a bad crystal, right? So we also want to examine the ultrasound head, right? Maybe change ultrasounds. If maybe look at it and you have enough gel and it's not changed, change the ultrasound. We may also have to decrease the intensity, right? Or maybe we're working on a really shallow area and we have her on 1 megahertz, right? And that's the deep penetration could be a problem. But either way, what we're going to do is discontinue and assess what's going on, right? Would we want to contact the PT? Maybe, especially if we know that it may be an ultrasound related thing. Maybe they're just not responding well to ultrasound. Okay, we may have to consider a different modality at that point. It happens. Some people don't like ultrasound. Some people like me don't feel anything from ultrasound. You know, you're going to do this to me. I'm like, yeah, I don't feel nothing. Right? Does that mean the ultrasound's not working? We told you, no, it's not. Because at that point, though, it's working at the cellular level is usually your good answer. Right? But in this case, when you're getting a burn, your first thing should be is stop. Right? Pause the machine. Look at your gel. What else could cause this? You're not moving the ultrasound head. Right? All of those can cause this problem to occur. I'm only going to do 10 of these questions, then we're going to call it here. All right. PTA is working on an acute care Florida hospital. Hello, Dr. O'Neill, right? Reviews the medical record of a patient with suspected renal involvement. So we know that they've got kidney problems. Which lab test would be most useful to assess the patient's renal function? At this point, do you have to know anything about the values? No, nothing about the values. Doesn't matter. Values don't care. Don't get those stuck in your head. That's going to be your first option. Like, I don't remember the values for platelet counts. Doesn't matter. You're not asking for values right now. You're asking which of the following labs is the best test. So platelet count. Nope. Platelets, not something we're going to worry about when we're talking about renal involvement. Hemoglobin and hematocrit and hemoglobin, H&H. That's red blood cells. Could it be a problem? Maybe. But the problem is hemoglobin and hematocrit are so related to each other. I would look at those both and go, those are too close to one another, so neither of those can be the right answer. Blood urea nitrogen. Where have I heard the UR before? Almost like in urine. So in this case, if they have a high blood urea nitrogen, you're in trouble. Right? Oh, okay, so that's the only one I have left. I know I'm making these really simple, but it technically is this simple. Number 7. Look at this. I guessed this one right, too. PTA attempts to obtain history from a patient that has recently immigrated from the United States. Let's say they're from Kazakhstan. Patient does not speak English. Why did I pick Kazakhstan? Because Kazakhstan is just an awesome named nation. I just love the name of Kazakhstan. Right? Uzbekistan is probably one of the second favorite of me, right? Just because they have cool names. We're in the United States of America. We're kind of boring. Uzbekistan. Patient does not speak English and seems intimidated by the hospital environment. Of course they're intimidated. Put yourself in this person's shoes. You're touring Uzbekistan and you end up with a fractured foot and you go to the hospital and everyone's speaking to you in Uzbeki, I don't know, third native language. Yeah, you're going to be intimidated by this, right? So the patient's freaking out. No one speaks my language. Happened to me when I was in Denmark for the first time. Got hit by a car, knocked me out. I woke up in the hospital and everyone around me was speaking Danish, and small is all I spoke in Danish, very small amount. And so they're speaking all around me and I'm like staring at them. And I remember the doc's like, I detected him say, his concussion must be worse than we thought. And I'm like, no, I don't speak good Danish. It was still my first 2 weeks there. I didn't understand what they were saying to me. They switched to English and I was fine. Right? But maybe you don't speak. Maybe they're from Croatia and you don't speak Croatian. Ask the patient to communicate in writing. If they write in Croatian, is that going to help you? Probably not. Ask another PTA or PT to help obtain the history. Well, I mean, if you've got a PT that speaks that, great, but that's taking them away from their patient. And that's not the best answer. Move the patient to a private treatment room. Moving them to a private treatment room is not going to help you understand their language. Request an interpreter is the best one. Or, Google Translate works wonders. I mean, it may not be perfect, but at least it gets the point across. Most hospitals, if you're in the acute care setting, have language line. And most times if you have a patient that doesn't speak English, somewhere in the room, there's going to be the language line phone. And it has 2 receivers, one for you to speak into and one for them to speak into. And when you speak into yours, the interpreter translates for them. When they speak into theirs, the translator translates for you so that you can communicate. Not the most effective when you're doing a therapy treatment, but at least they understand then what you're going through. Come on, did I get any wrong? Oh, gosh, I got another one right by guessing. 2-year-old T10 spina bifida receives PT for gait training. Spina bifida, spina bifida, spina bifida. Remember, that's where the neural tube didn't close. So we've got some spine issues that are going to look a lot like a spinal cord injury. Initially, the preferred method to teach child how to maintain standing with the use of, okay, I'm looking at this. My STEM is preferred method for standing. That means I'm looking for safety. So I've got bilateral hip, knee, ankle, foot orthosis, and forearm crutches. Not safest. Forearm crutches automatically rules that one out. 2 we'll get back to. 3, bilateral ankle, knee, foot orthosis, and the parallel bars. Not a bad idea, but they're T10. So if they're T10, they don't have a lot of those hip functions, right? So we're missing a lot of our hip flexors and hip extensors. So we need something at the hip as well. So that's why the number 1 had maybe a better orthoses. The forearm crutches out. Number 3 has bad orthoses, but a good assistive device. And then number 4, if knee, ankle, foot orthoses are out, then just ankle, foot orthoses are 100% out. Right? So the only thing I have left, even if I had no idea what a parapodium was, even if I had no clue, don't remember what a parapodium was, by ruling out all those others, the only thing left is parapodium and parallel bars. We know we want, whenever you see most safe type thing, preferred method, parallel bars is probably your safest bet. So if I was going through this and didn't know, I'm going to rule out 1 and 4 automatically, just because I know the AFO is wrong on number 4, and I know that the forearm crutches is wrong on number 1. So that leaves me with 2 and 3. Then I have to go T10, KAFOs, not enough, and rule that one out. The only thing I have left is the parapodium. And parapodium kind of stands them up straight and gives them support so they can get up in weight bearing. Are we initially going to walk with the patient? Probably not. We're going to initiate standing to start with, but at least that gives them the ability to work out. Ah, there's Mike. Appreciate it. Mike's already gone. He left us already. Ah, I missed him. All right, 9. Oh, this one I intentionally got wrong. I remember this. So PTA treats a patient with end-stage renal disease. Good Lord, not another renal disease question. I feel like all my questions are renal disease questions. No, that's just what you got for 2 questions. Relax. For general deconditioning, what other symptoms are most likely to demonstrate? So when I'm looking at this, patients in end-stage renal disease, the first thing I can rule out is increased urine output. Their kidneys are failing. They probably have to have dialysis. Urine's not going to be coming out very easily. They may even have to be catheterized. So increased is out. So that leaves me with 3 and 4. So then I got to go, okay, well, is it increased urine output in polycythemia? Or is it increased urine output in anemia? Well, in that point, then you just have to pick the best option there, right? My best option here, and I did this on purpose because I was not sure about this. And so then I did what a student would do. I picked my answer, which was 4. And then I went back and I looked at it and went, oh, no, 3 sounds better. And I changed it. And it goes to show you your gut instinct is right. Right? I changed it just because I wanted to use this as an example. My gut said anemia. Right? Because I didn't remember polycythemia, if you want to be 100% honest. I know it has to do with platelets. I just don't remember everything about it. But what's happening here is, right, anemia, meaning that my red blood cell count is not transporting oxygen as effectively, right? So that would have been the better answer. It should have been the answer I picked. Unfortunately, I'm a silly person and went back and changed it. Changing an answer, that just cost me a question. This question here is a level 2, right? That would have cost me some points. And that, again, could be the difference between passing and failing because I changed my answer. Look at number 10. PTA works with this patient 6 weeks following total hip arthroplasty, post-lateral approach. So I see post-lateral approach. The first thing that should come into my head is no flexion, no internal rotation, and no hip adduction. Got it. Right? Patient's med history includes Graves' disease. So does my posterior lateral approach have absolutely anything to do with this at this point? Nope. That's just a distractor, right? What the big point here is, patient has Graves' disease. What intervention should the therapist avoid when treating a patient? Well, supine resisted hip lateral rotation. Well, I mean, internal rotation is what we want to avoid. Standing hip abduction with ankle weight. No, adduction is what we want to avoid. Stair training. Well, that's going to be silly. If they have stairs in the home and we have to avoid stair training, that just seems silly. So then I have to think Graves' disease, excessive heat causes Graves' disease to flare. Oh, I don't even remember what Graves' disease is, right? Well, just looking through this, 1, 2, and 3 are stuff we're going to do with them, period. Right? They just are. So my only option is ambulation in a warm pool. And why is, I'm looking at that going, that is definitely the odd duckling out of that grouping, right? Because specifically it says warm therapy pool. So my brain's going to be drawn to that and go, I'm betting that's the right answer. Because if it's not, I'm in big trouble because the rest of the stuff is probably stuff I'm going to have to work on with them. And just so that you can see, I just took this. I'm going to go back to my scoring summary here. Go back. And again, I went through and did this test. Time remaining, so at 25 minutes remaining. I took the 25 questions and was at 5 minutes. And just doing that, I had 18 out of 25 right, just because I didn't look at the questions. I went by just test taking. That would be enough to pass the boards at a 72%. I mean, ideally, I'd probably want 80 to be safe because 80 would be really close. But I just guessed through them and I changed one of the answers on purpose. I'm going to stop sharing here. Does that help understand how to kind of look at questions, guys? Somebody respond to me that I make sure I'm not just talking into the void here. Like Adriana, Kaylin, Natalie, somebody, Natalia, somebody say something. I feel like I'm talking into the void.
I think it was a great review. And
okay, thank you, Kaylin. I appreciate it. I was like, I know I'm talking for most of the people on the recording, but it just at least helps me to feel that I've still got some live souls here. Are there any questions that you three, because I know that Natalia is with you, Kaylin, that you three or Adriana, you have a question on that I can answer at this point? I just wanted to hope, good. I wanted to hope that this makes a little bit more sense to you. So here's the deal. I am going to make open to you guys from now until your boards, because you guys are very lucky right now. I only have an afternoon class, right? What I am going to make open to you guys is if you could talk to maybe people that, because you guys know who's testing in January and April, talk to them all. See what day would work really well. And every day, every time on that week, so like starting next week, if Tuesday at noon works well, all right, well, noon wouldn't work well. Let's say Tuesday at 11 works well. I will make my schedule for you open from like 11 till 3 o'clock or something like that. And you can just come into the room. I've got a question on this. Okay, great. I'm out, Mr. McKeever. Peace out. That gives you guys a free time to come in and talk to me. I'll schedule a good block of time that you guys have. And I may even do 2 days if it's needed. But right now, my main goal is to make sure you guys pass these boards and pass it this time. Done, out of the way, no further gigs. And I've got free time right now, so that's what I want to do. Dr. O'Neill's got a lot of classes right now and dealing with the program director stuff. Dr. Vresta's got her mess going on. Dr. Sokel's teaching a lot in the other class, but I'm pretty free right now. So you guys are in a very, very, very lucky situation right now that I'm kind of free. The only thing I'm really teaching is math and helping out with anatomy when I can. So we're going to schedule a regular every week session. No one shows up, no one shows up. I'll still be there. I'll be like, hey, I'm done twiddling my thumbs. But at least I'll be there. So that way, if, you know, Natalia, you're like, oh my God, I got a question on, I don't know, spina bifida, and I don't remember about it. Come in, we'll talk through it. And then you're like, okay, I'm done. Deuces. Head out. Does that sound like a fair plan for you guys? I want to make myself available for you, is what I'm saying. Sounds good? All right. Well, I'm going to stop recording. Actually, Dr. O'Neill, do you have anything else to add before I stop recording? Okay, so Dr. O'Neill says she has nothing else to add.